silence button. That's our favorite button on the vent, but we need to be a little better than that button. So let's get started here. All right, so you've all probably seen this and heard that unfortunate noise as well. So that's your alarm going off on a vent. So various reasons for that. It kind of makes you pause and kind of sometimes makes you freak out and make you doubt that you know what you're doing. But this is once you hear that, see that going on, it's you just need to pause, have a quick system that you run through to troubleshoot this and try to figure out what's going on. Now, this is a very in-depth and advanced topic. There are much better people to talk about this topic than me, but I can at least scratch the surface of it. And it's one of those things that if you know most of the basic stuff to look at, you can at least rule all that stuff out. Now, every now and then you're going to have to still phone in a friend and get help, but we can really kind of look at the vent, look at the patient, decide some things that we can maybe troubleshoot at the bedside to get that darn alarm to stop going. So this is obviously our usual freak out moment once we hear that. And my favorite thing always do, and most of our favorite things, is to quietly walk by the bed and just hit that alarm button and then keep on your day. In the attending office, I can hear that damn alarm going off, and I can sometimes tell when you guys just press it and I go over there and you're back at your computer already. I can tell there hasn't been any time to really sit at the bedside and figure out what's going on with the patient. So we're going to try and go beyond that alarm silence button. So some things we need to do once we get to that point where we have an alarm going off. It's okay to silence that vent. It's hard to think with all these alarms going off. But after that, we need to then take the next step. We need to analyze what's going on with the patient and the vent. If we find a problem with the fix, we can go ahead and fix it. And most importantly, reevaluate the patient, reevaluate the vent. You don't fix something and walk away. Vented patients are very advanced and very scary and very critical. So you got to go back and reevaluate that patient, decide, did I make the right move? Do I need to make more moves and not just walk away from the bedside? So I'm going to be running through this, but stop me if you have any questions. So step one, like I said, is analyze. So the very first analysis that we do, and this goes with all patients. This is one of my favorite things I ever learned in medicine was from Caro back in the day, the sick versus not sick Caro paradigm. And this goes for vented patients as well. Is this patient stable or are they unstable? Because that is your initial step in the pathway of, do I pump the brakes or do I step on the gas? Do I need to act in this situation? Many of these situations, we hear that alarm, we rev up and we want to act, but if we take a step back and look at the patient, analyze the situation, we realize, okay, this patient's saturation is fine, their blood pressure is fine, I can kind of bring the tone of the room down and take a more stepwise approach as what's going on, as opposed to my patient who's crashing, okay, now I really need to act in the next minute or so before things get really bad. So again, taking that global picture, this just isn't just a vent, this just isn't just a patient, this is a vented patient. So these two things are trying to work in tandem. So taking the whole perspective, looking at the vent, looking at the monitor, and looking at the patient, not getting lost in the numbers and the waveforms, but looking at the patient as well. So we've determined sick versus not sick or stable versus unstable. Now it's man versus machine. So this is very important anytime we're dealing with anything. If we're dealing with LVADs, if we're dealing with trachs, especially the vents, is this a patient problem or is this a device problem? That first step can be a huge difference in you being successful in what's going on. When that patient comes in with a trach emergency and we forget to figure out, is this a trach or the patient, you can spend a lot of time doing the wrong thing when you don't realize, oh, this is a trach problem and the patient just hasn't suctioned the trach out. Same with the vent. Is this a vent problem or is this a patient problem? So taking a quick step to figure that out, you may not be able to initially, but having that mindset can go a long way. So very first patient we're going to talk about here is a patient on the vent for whatever reason, and they start crashing in front of you. Alarms are popping off. You have this patient, they're hypoxic, their blood pressure's crashing. This is kind of that basics of the crashing patient on the vent, and we need to have some mindset that we go through when we talk about this patient. And like I said, we've determined this patient's unstable. Now we want to try and determine vent versus patient. So how can we do that? What's one initial step that we could do to start down that pathway of determining, is this the vent or is this the patient? What's that? Dopes. Before we go down dopes, we're going to talk about the next. What's the very first maneuver we can do? Take them off the vent. So take the vent out of the situation. Now be careful. If you have someone in APRV or something, I would just go flying them off the vent, like know what you're doing. But if that patient starts looking like crap, think about, can I maybe pop a bag on this patient and bag that patient and see if that maybe improves things. You can learn a lot by bagging a patient. You are now feeling that bag. If those breaths go in really well and within a minute those sats start climbing up, okay, this problem probably a vent issue, not that the vent's broken, but maybe my settings aren't great. And now I can tailor that. But if I bag that patient, it's hard to get those breaths in. Okay, this might be a patient problem. Do I need to allow them to exhale? Do I need to treat the underlying problem a little bit better? So it's amazing how much you can learn by bagging. Don't just bag the patient, bag and feel the patient. Feel what that bag is like. Feel what the breaths are like going in. Feel if there's a full exhalation. It'll tell you a ton about that patient. We have that crashing patient in front of you. Like Blake was just saying, we need to go ahead and go down a nice little mnemonic, which you said rightfully is the DOPES mnemonic. You guys have probably talked about this before, but it's worth going through it real quick just to know what you need to run through your head when you have a crashing patient on a vent. So what's the D stand for? Anyone remember? Displacement. So does something happen with this tube? This tube is a nice bridge for your air to go from the outside to the inside. So is there something with that airway that is now not allowing the air to go through? So a couple things we can think about. Tube depth. My biggest bane in emergency medicine is the second we get that tube in, we have to yell out our name and the depth. We have a very critical situation going on, and we now have to give this information, which is really annoying, but that does help on the back end. If initially you intubated and the tube's at 24 and now the patient's crashing and the tube's at 18, okay, something happened. In shifting that patient, doing something happened. And that would make me think, okay, this is probably a displacement problem. Especially true in our pediatric folks. It's good to remember how the tube actually moves when the patient's neck moves in pediatrics because it's counterintuitive. If you flex the patient's head, often the tube moves down. I see people writing, you're welcome to write, but remember these are recorded as well. But write all you want, but do remember these are recorded. And if you extend it, the patient's neck, that tube can actually come up out of their way. So if you think we're doing maneuvers in switching the patient's head and moving stuff with these pediatric airways, there's such little room for air, we might extend that neck a little bit and now the tube's up out of the trachea and it completely changes the situation. This is why often we see C-collars on kids after we intubate them. Not because they're trauma, but because we want to avoid, it's such a smaller air, room for air as the adult patient. We want to avoid that tube encroaching out of the trachea. Another great way to look for displacement, that beautiful end-tidal CO2 wave. End-tidal's way overused in emergency medicine, in my opinion, but this is where it's great. If you have a beautiful waveform and now you don't, something happened. And that tube may have dislodged. So having that end-tidal waveform can be great. There's a lot more nuances to end-tidal CO2, but the basic best part about CO2 is seeing if ventilation is getting to that sensor. And finally, look in the airway. When in doubt, pop that blade back in, look in the airway, make sure this is your gold standard for making sure you haven't had tube displacement, is visualizing the tube going through the trachea. All right, obstruction. There are so many reasons a tube can be obstructed. People bite on the tube, people get secretions, vomit, blood. We've all seen this. We've all seen crap coming out of the tube. So this is a problem if you're obstructing the flow. Dr. Rasso was talking about resistance earlier. That will increase your resistance. You've now taken your tube diameter and you've cut it in half because of gunk in the tube. That's going to be an issue. This is a patient I had probably 3 years ago. Heard the alarm, woke up in the attending office and God damn it, had to get up, walk to the recess bay because alarms are popping off, patient's hypoxic and couldn't figure out what the hell was going on. What's going on with this patient? Tube's bent. Yep. It took me 10 solid minutes to figure this out. And that tube was bent. And I'll just boop and then bag. Patient did much better. So just think of your basics. We sit there and stare at the vent and all this stuff, not realizing I just had to straighten the person's tube out. So this is where stuff like dopes seems dopey and dumb, but it's the basics to not forget what's going on.
Or did you recreate it?
I'm not going to answer that question. I can't remember, but I'm pretty sure I said to the RT, hold on, I need to take a picture of this. And they kind of looked at me, what are you talking about? And because I was doing this lecture like 3 days later. So I think that was the original. Anyway, P is for pneumo. So patients on vents have a high risk of pneumo. Any of us who were around during COVID saw this. We helped cover the North ICU at nighttime during COVID. I have never seen so many pneumothoraces and put in so many pigtails in my career. In one night, I think we had 6 patients pop pneumos in one night because their lungs were so fragile. The second alarm started going off, you essentially said, oh shit, this person has a pneumo. So when you have a very sick patient like that, ARDS stuff, you get very fragile lungs. So checking to make sure this isn't a pneumo. So doing our bedside ultrasound. I'm looking for our evidence of pneumo with that, getting chest x-rays, all that stuff, just making sure that that's not the issue, because that's going to completely change the dynamics of your lungs once you get a pneumothorax. And then E is equipment failure. So there's lots of equipment involved in mechanical ventilation. There's the basic stuff and the advanced stuff. It all has to work to make sure your patient is properly oxygenated. So basics of, is my oxygen plugged in? Now the vents probably won't let it run if the oxygen isn't plugged in, but making sure the basics of that are working. Is my balloon up? So checking for leak. Sometimes you can hear a leak, but often you can't. So just very, very basically pushing on that balloon. Does it feel like my balloon's inflated? Because that balloon can pop when it's on its way in on the teeth. And like I said, taking the vent out of the picture is a very different situation. I pop that bag on and this patient bags beautifully. Very different situation if I'm really having to crank on that bag. That's a different scenario that I need to treat differently. And then I always say dopes with an S because I think breath stacking should also be included with that. Because with our asthmatic patients with obstructive pathologies, as that patient inhales, they can do what's called breath stacking. So we obviously have our alveoli, we have our normal on the left, asthmatic on the right. So asthma is going to be defined by airway obstruction, by mucus, by inflammation, not allowing full exhalation from the alveoli. So every time that patient inhales, they might get a little more trapped air. Inhale again, a little more trapped air. You can see if that happens and keeps happening over time with each breath, it's going to cause physiologic problems. One that's going to be obviously inhaled, impaired gas exchange and also decreased venous return. As we increase our intrathoracic pressure, we're not getting a return back to the heart. So you can actually get low blood pressures and some issues like that. So what do we do if we think the patient is stacking breaths? What do we do? Okay, why? Okay, we want exhalation. They're trapping. We want to encourage them to exhale so we can detach that bag, either allow passive exhalation or sometimes actually put a little pressure on the chest and allow that breath to come out. And you'll listen and hear 30 to 45 seconds of deflating their chest. And then you can put them back on the vent, adjust their settings, and hopefully get some better ventilation going on. In general, there's a lot to this, but in general, we're going to try to aim for that lower respiratory rate. So our severe asthmatic, we put them on the vent and they're breathing 20, 25 times a minute, they have a higher risk of trapping that air. So this might be a patient that we're sedating more, or even worst case scenario, paralyzing, to now get their breaths down to 6, 8, 10 a minute to allow full exhalation based on what we're seeing on our waveforms. And we'll go over those waveforms in just a second. All right, so if you've gone through dopes and everything is checked off, the patient might just be getting sicker. So that's just something you have to take into account. The patient might be getting sicker, and now we need to turn our attention more to the vent to see what's going on and make some setting changes. All right, so let's say you've gone through the dopes, that alarm keeps going off. What do we do now? We can't just bag the patient the rest of the shift. We have to figure out the next step of how do we treat this patient. So we're going to turn our attention a little more to the vent. And we're going to go through the vent, what the waveforms are, the very basics of it, some of the buttons and what they do. This vent right here is the vent that we mostly see in our emergency department. This is the Maquette Servo I. You might see some variations on it based on if it's newer or older, but in general, this is the vent that we're seeing in our emergency department. Now, remember, this is the tip of the iceberg. We're just covering the very basics of the vent. There is so much more to this. But I just want to get basic understanding of what might be going on and how we can maybe fix that. So different waveforms on the vent. This is the basic screen when you see it. Up at the top, the blurred part, that'll be the settings that you have and some other stuff as well. But we're going to go through each waveform here. So there's first waveform right here, the yellow waveform. This is your pressure waveform. And then we have some yellow numbers on the right over here. So we have our pressure waveform. So that's telling us how much pressure is going into the patient. And we have a baseline pressure here. And we have, what's this gap right here? There's a 0 down here and the waveform baseline's up here. So what do you think accounts for that gap? Peep. So over here we see a peep of 5. So that's why this isn't actually returning to 0, because on exhalation, the patient is still receiving some sort of pressure. Over here we have our peak pressure. So that's the highest pressure that the vent is recording when it's ventilating the patient. Next one down is our green one. This is our flow waveform. So this is the flow going into the patient. and then coming out of the patient as they exhale. And we have a couple other numbers over here. Our 15 number we're seeing is our respiratory rate. So it's going to tell you how many times how many times measuring that the patient is breathing. So that's where if you're trying to figure out what's going on with the patient, you're going to say, does that match what my setting is? I sometimes ask, hey, what's the patient breathing? And we say, oh, they're breathing 15 times a minute because that's what we set it at. But the patient's actually breathing 35 times a minute. So this number on the right will tell you what the vent is actually measuring that the patient is actually breathing. And then the blue one on the bottom, this is our volume curve. So as the flow goes in, it's creating a volume curve in the patient and then decreases back down. The numbers over here we'll see on this 7.3, that's our minute ventilation that the machine is measuring. So that's a volume in your respiratory rate. And then we have the ventilation in and ventilation exhalation. So inhalation, exhalation. In general, those numbers should match pretty well. Now you get variation with different modes and what's going on with the patient and coughing and stuff. But if you have a lot going in and a little coming out and your patient's not looking well, that's when you start thinking, is this air trapping? That's when you start thinking, is there a leak in the cuff? Those are little kind of nuanced numbers that you start looking at when the patient's not doing very well. All right, so now the nice thing is this main screen, there's other screens in the vent, but this main screen has most of the basic stuff that we need to look at when we have an alarm going on. It's going to tell us most of the main numbers that we need for basic interpretation, especially of our high priority alarms that we're going to talk about. Something I realized along the way is that a lot of you folks don't understand or aren't able to see on the vent if this is a breath being given by the vent or a breath that the patient is taking themselves. So how do we tell the difference? This patient, I can tell you, is taking these breaths on their own. How do I know? Yeah, this little purple thing right here. Very basic, very useful information I don't think we teach well. When it has a little pink uptick there and that little T up top, that is a patient-initiated breath. It's very helpful to know, is the patient taking these breaths? Are they stacking breaths on top of each other? Are they double triggering? All this stuff, that nice little piece of information, if it's solid green the whole way, that means that's a breath that's only given by the vent. All right, so when we have an alarm on the vent, how do we figure out what's going on? Well, in this vent here, if you watched the video before, that red box in the upper right corner is flashing at me. It's sending off alarms. There's a big red box flashing around my peak pressure there. So it stands to reason that it's probably a problem with my peak pressure. It's hard to read on this image right here, but that the upper rectangle up here says P airway high, meaning peak, the airway pressure is too high. So how do we interpret these alarms? There's lots of different alarms you can get on the servo, but in general, there's high priority, which are red, and what do they call it? Medium priority. I put high priority, but that's wrong. But there's high priority, which are the red ones, and we'll call it medium or low priority, which are the yellow ones. So the main ones you're going to get that we need to worry about are high airway pressure, apnea, generally not good, high minute ventilation, and low minute ventilation. Those are the ones that we can really interpret and do stuff about. There's going to be more, like if oxygen isn't hooked up to it, it's going to give you that, but hopefully you can figure that out. And then our lower priority ones are high and low respiratory rate, high and low PEEP, and then there's others. But I really want to go through more of the red high priority ones that we might need to actually act on in the acute phase. So the pressure airway high is, I think, the one that kind of gets us the most. We see that one a lot, and there's varying reasons for that. So I'm going to focus a lot on that. So what this is telling you is the pressure in the airway is high, usually a peak inspiratory pressure. So that very tip of that pressure curve is higher than the alarm threshold is set on the vent. So you have to take into account, what is my alarm threshold, and then what's the patient doing? So if you have a patient that looks okay, and that thing is just popping at you, then go ahead and maybe look at your alarm thresholds and say, okay, does this make sense? On this picture here I put up before, the alarm threshold is only, or the peak inspiratory pressure is only 20, which isn't high. I had deliberately set the threshold down because I needed a video for the lecture. So if the patient has a peak pressure of 20, which isn't very high, and the alarm's popping at you, it might just be that their threshold is turned down. And if you don't know how, ask your RT or attending, how do I change these alarm parameters? So that'll kind of help to know. So what are some causes of increased airway pressure that might be making this alarm happen? What do you think? Okay, so we talked about is almost like the dope mnemonic, increasing resistance through our system. So secretions, biting the tube, stuff like that. What else? Kink tubes, all the things that can obstruct, increase resistance, obstruct flow. What else? Okay, worsening patient, sick patient or worsening patient. Their lungs aren't stretchy anymore. They're going to be having increased airway pressures. Anything else you can think of? So what if the patient goes and it's popping that alarm? What's happening? Patient's coughing. They have a tube in their throat, they're coughing, or there's ventilators asynchrony, which we'll talk about as well. The patient and the vent are not working well together. So those are some things we can think of. So Dr. Ressa went over the resistance versus compliance. So again, the resistance is anything obstructing flow through the system. So that can be the tube, that can be the trachea, that can be the bronchi, that can be the alveoli. Anything obstructing flow, whether that's worsening disease, mucus, patient biting down, that's going to be your resistance issue. Compliance is going to be that change in volume with a given pressure. So as lungs get sicker, it's like blowing up the balloon. When your kind of balloon's like moderately blown up, it's very stretchy, easy to blow. But as that balloon gets very inflated, it's very hard to blow because the material has reached its max compliance. So when our lungs get very sick, their compliance change and they may be much stiffer lungs now. So how can we tell if this is a resistance problem or a compliance problem? Now that question is more advanced than we're going to go through, but I want to go through the very basics of some things we can look at in the vent to try to tell which one these can be. So we're going to look at our plateau pressure. So plateau pressure is the pressure in the lung after a certain volume is delivered. So this is a gross estimate of the lung compliance. So you have our pressure that rams into the lung, and then as that tapers off and comes to equilibrium, this is going to be our plateau pressure. And it can kind of help tell you like the stiffness of the lungs. Now, does anyone know how to check a plateau pressure on the vent? Both of you got good. Inspiratory hold. So the way you do that's actually pretty easy because you can see this pressure here. If we weren't to do anything, this waveform would just come back down to zero. But if we can actually artificially hold that inspiration for that patient, it's going to allow the airways to equilibrate and it's going to give us that plateau pressure. So luckily on the vent, there's this nice little button called inspiratory hold. So if we hold that button, it'll actually hold the next ventilation and hold that for as long as we hold that button. Now there's a certain time it'll time out, but it will hold it long enough to give us a measurement. And now we can see what that plateau pressure is. So here on this vent, we can see. So what I usually do is as they're breathing, I'll just go ahead and hold it. It gives me that plateau and then I let go because I'll show you also here, it's not like you have to measure it yourself. It gives you that number. There are certain parameters on how long it'll hold and I can't remember any of that. So as they're breathing, I just go ahead and as I see them take a breath in, I go ahead and hold it down long enough to get my measurement and then I release. So if you hold that in, you can see here on this vent, it is, there you go. It's holding our plateau pressure here. So it's actually holding this patient's inspiration in, and then as we let go, boom, it goes back to baseline. And then it gives us this nice P plat over here, P plateau. Now, if you're not seeing these numbers over here, it's because there's a button down here. It says next page, but before it's pressed, it says like additional values. So if you're not seeing those numbers, you just need to press that button that says additional values. It'll bring up the rest of the numbers. And now this gives us an idea of what that plateau pressure is. And this is when we can start working through, is this a resistance problem? Or is this a compliance problem? So in general, and there's a lot to this, but in general, if our P peak minus our P plat is greater than 10, it's going to be more of a resistance problem. And again, this is getting to the very basics of this, but that's going to be more of a resistance problem because this isn't the compliance changing in our lungs. This is something with the resistance of the system. So that's when we start thinking about, is this ET too small? Is there kinking, biting, secretions? Is this bronchospasm that I just need to go ahead and treat? So then we're in our analyze and fix phase. We figure out what's going on. So usually one of the first things I do with this is I go ahead and push that suction catheter down the ET tube and suction out. If you're in recess and you don't know how to use the suction catheter, please have RT show you. It's because they're not always there. We have great RT, but they can't always be at the bedside. And like we were saying earlier, if you're at a community shop where you don't have RT, you need to know how to use this stuff. So I usually go ahead and put that down and suction out, and that's my kind of step one. If a bunch of crap comes out, okay, I'm now going to watch the vent, see if it gets better. Because often it's just there's a lot of secretions the airway. If that comes out completely dry, I'm thinking, okay, this might be something else. Other stuff, mucus plugging. Ultrasound, look at the lungs. When in doubt, if someone really looks worse on a vent, I have a very low threshold to get another x-ray. I'm going to do all my immediate life threats and fixing up front if I can, but pretty low threshold to go ahead and get another x-ray because you'd be surprised how many times you just see a whole lung wide out because now they popped a mucus plug. So that would need a bronch from ICU to go ahead and get that out. Kink tubes, like I said, maybe the patient just has more bronchospasm. They need more nebs. They need to treat their disease a little bit more. And then finally, we need to think about patient versus machine. So this is where you always hear, he's bucking the vent. This guy's bucking the vent again. This is more than just bucking a vent. This is the patient and the vent not working well together. And this is what's called ventilator dysynchrony. So there's different terms for patient ventilator dysynchrony. There's other terms for it, but in general, this is what we're talking about. This means the patient and the vent are not working well together. So often we get exasperated and our nurses get mad. We just want to sedate the patient more. We need to take a step back and say, okay, why is this patient not working well with the vent? Don't just blame on the patient. It could be that our settings are off or something's not right. So first off, I think we do need to focus on patient comfort. Dr. Rasso talked earlier about this. I'm in complete agreement. One of the worst things we can do is put someone on a long-term benzodiazepine drip and throw them up in the ICU. That's longer ICU days, more mortality, more pneumonia. So we try to avoid that. But I think we do need to keep some level of patient comfort in these because this is a very uncomfortable thing. So it might just be the patient's awake looking at you, coughing, trying to yell at you and cuss you out. That might just be a patient comfort issue. So see if a little bit of sedation maybe helps that patient work better with the vent or determine does this patient actually still need to remain intubated. So, but the dysynchrony is often an issue with ventilator settings. So now we have to figure out how can we look at this vent, look at the waveforms it's giving me, and determine are there maybe some things I can improve to allow this patient in the vent to work better together. So we're going to show some waveforms. And I know I just showed you waveforms 5 minutes ago, and now you're expected to understand them. But I'm just going to walk through them. I'm not going to expect you to be able to interpret them, but just walk through them so that next time you see this, you can say, oh, I can actually look at this and maybe figure out what's going on. The other thing to remember is this is what your waveforms usually look like. They're not as pretty as the ones we put up here for teaching. They usually look like this crap. That's stuff all over the place. And you're trying to figure out what's going on with the patient. So do know there's a little difference between reality and teaching. So I want you to look at this waveform right here. So you have a patient, our alarms are popping off. Patient just doesn't look comfortable, doesn't look like the patient and vent are working well together. There's obviously boxes pointing to stuff. But what do you think is going on in this patient? What do you think these arrows are pointing at? Let's focus on the pressure, the red pressure curve. What do you think? Any ideas? Why is this patient and vent, why are they not working well together? Any ideas? So what do you think that first deflection down, what do you think that is? What do you think is happening in that deflection? What's up? So what do you think is happening right here? It's also happening here. It's also happening here.
Some low pressure.
Yeah. What's happened? What was that? The patient trying to initiate a breath. Is the ventilator giving them a breath? No. So the patient's trying to breathe. Let's say, I don't know, let's say 20 times a minute. And the vent's just saying, no, I'm going to give you 10 a minute. So they're not working well together. So we'll read these little things here. I hate reading off slides, but this is too nice of an image. So mid-breath, the patient tries to inhale more gas than the ventilator is willing to deliver, generating a negative pressure and some negative flow. So we can also see our flow curves are going to correlate with that as well. So now the patient is trying to initiate a breath, but they can't because the inspiratory valve on the vent is closed. So what do you think the main issue with this situation is? You won't encounter the situation much because this depends on your vent settings that we don't use too much. What do you think the main issue is with this vent? Do you think we have the right vent setting? No. Okay. This vent setting is only giving breaths when the vent wants to give breaths. It's not allowing any patient triggered breaths, which is something we don't often do in the ED. But just know that's going to be your issue. Your patient's really trying to breathe, but the vent was locking him out from breathing. So this is where a simple change in your settings would help the situation a lot. All right, what about this one here? So kind of similar to that last one we saw. What do you think's going on up here? So what are these negative deflections on the red pressure curve? It's negative pressure. Patient trying to breathe in. So now what do you think the issue is? What threshold? So your trigger, this is a trigger issue. And we can kind of see it in this green curve here. So the patient tries to initiate breaths, but the trigger threshold is set too high. So there's different types of trigger. There's flow trigger and there's pressure trigger based on if it's negative pressure of the patient inspiring in or just the flow of air going across the trigger. So this patient, for various reasons, it could be that they're auto peeping. It could just be that our vent settings aren't great or whatever's going on with them. They're not able to initiate. So the vent would give them ventilation. So we can see here in this green line, once they hit that trigger threshold, it then give them a breath. It's like, oh, you want a breath? Sure, here's a breath. But all these other ones, they were working their way up to hitting that trigger. So maybe they're a neuromuscular disease that's getting worse. Maybe again, they're auto peeping. So now they're actually having to overcome more negative pressure. We'll talk about that a little later. But for some reason, they can't trigger the breaths. So this is, again, this gets into a little more advanced stuff. But once you realize that, you just look and say, man, they're trying to trigger, but it's not. And the machine's set to allow them to trigger. Now you got to think of, okay, what's the problem? And this is where you get RT, you get IC, you get your attending to say, hey, how do we mess with these trigger settings to allow more ventilations for the patient? All right, what about this one? So again, I'm not expecting everyone to just know what's going on, but what do you think? So it's pointing to something here. So we'll just say this patient and the vent are not working well together. What do you think? Any ideas? I'm going to go back real quick. Look at the red curve on here. Kind of a nice slope up here. And then look at this one. What do you think's happening here? Is it adding pressure to that curve or is it biting pressure off of that curve? What do you think? Just guess. Guess. Nope, taking pressure off. So, so you have see this kind of faded red right here? That's what you'd expect. We now have two merging curves, one positive, one negative. So this is a negative pressure curve that's biting off that pressure curve there, right here. You have a negative deflection called scalloping. So just ideas, what do you think could be happening? In the middle of that vent, giving that patient a breath, you have a sudden negative curve that's overcoming that pressure. What do you think? Yes, the patient's trying to breathe in more. The settings we have are not giving the patient what they need physiologically, whether that's just initial settings aren't enough, whether that's the patient is getting sicker. For whatever reason, that machine's giving them air and they're going to try to get it as fast as they can. And the machine's actually cutting them off. So again, this can be a couple things. This can be inspiratory time. So based on their physiologic need, that the machine may not be giving them enough breath fast enough. So they're trying to do that. It may not be breathing enough for it. Our tidal volumes may not be right. There's lots of reasons for it. The whole idea of this is just see that and say, this isn't right, and we need to do something to fix it. So negative pressure generated by the patient deforms the shape of inspiratory pressure time curve. That's called scalloping. So just look, again, you're looking, this flow curve doesn't look right. You don't have to immediately know what it is, but sit down there and say, hey, okay, what could possibly be going on? On the right side, increasing the flow rate results in more normal looking pressure time curve. So in this patient, they're able to increase the flow rate, meaning giving them air faster, and that patient doesn't feel air hunger as much anymore. So this is an air hunger problem. And this is just more obvious evidence of scalloping. That's just the term I wanted you to see. So big scalloping. And then severe starvation here. So that's what, this is what that curve should look like. If something's biting a chunk out of it, something ain't right. All right, and then this is a little different case. What do we think here? And again, oh, sorry. Yep. So what do we think here? Any ideas? I don't totally expect you guys to. So what's happening at the end of that at the end of that pressure curve. What's happening up here? Remember, Dr. Ross was talking about this setting will give a constant pressure. What's happening here? Try to exhale. So in this setting here, their inspiratory time is too long on the machine. So it's still trying to give them breath, but they're trying to breathe out at this point. And this is where we get this gap in our flow curve down here. We have our breath in, a gap, and then out. So as they're trying to breathe out, that machine's still trying to give them flow. So again, very little nuances, but just looking at saying that something's not right about the curve, differentiating positive versus negative pressure, and then you can kind of work out what could be going on with this patient. All right. Okay. Let's get that. There we go. All right. We see this a fair amount. What's going on here? Does this look right? What's weird about it? So stacking is a term you could use for it, but stacking, this can cause stacking. So a more broad term is going to be double triggering. So do we breathe like this? No, we don't. So something's happening where that machine, boom, boom, is giving 2 breaths at one time. Sometimes you'll see even more than that. So that ain't right. Something's not right about that. So a couple different things that can cause this. Any idea of what could cause? There's lots of things, but any ideas? Anyone? So remembering that our ventilation trigger is caused by a change in pressure or a change in flow. So if the patient is coughing, it can trigger it. This can also just be the patient coughing or hiccuping. You can actually get, if there's condensation in the tubing, and this is a flow trigger, just that condensation sloshing back and forth can actually trigger a breath. Having too sensitive of a trigger. So if it's like what you call a hair trigger, where that thing just triggers for anything, it might start giving double breath. So just know that this isn't right, and where there are some things we can do to go ahead and fix it. Because you imagine how uncomfortable that is. Patient takes a breath and immediately, boom, the machine gives them another breath. So this can cause major dyssynchrony for your patient. All right, and what is this? Oh yeah, so what's going on here? It says it up there. What's going on here? What's going on? What's that word at the very top say? Autopeep. So this is autopeep. So autopeep is when you start getting trapped air from obstructive pathology. In each breath, you start building up more and more PEEP. So we have PEEP from our machine, but autopeep is intrinsic PEEP. So that's as we build it up in our system from our physiology. Now this can cause a lot of issues, but the issue here is that now it's changing what it takes to trigger that vent. If that patient's pressure trigger, let's say, is -1, but now they built up 10 millimeters of mercury of water of autopeep, they now have to generate -11 pressure to trigger the vent. So you can see how much harder it is for them to actually overcome that pressure gradient to trigger the vent. All right, so that was the basics of those flow curves and dyssynchrony. When in doubt, phone a friend. These are some of our RTs. As Dr. Rassa said, I believe as well that we need to be able to run these vents, but these folks are super knowledgeable. So get them involved, ask one of us. If the ICU is involved in the case, it's great to come down, just go to the bedside. Hey, can we go through these flow curves and let me know what's going on? Any questions so far? That was all the high airway stuff. It's all downhill from here. All right, so we talked about resistant tissue. Now we're going to talk about compliance issue. Like I said, your plateau pressure is going to be a measure of the compliance. So if you run that plateau pressure and it's super high, so that difference between your peak and your plateau is less than 10, we're now thinking more of a compliance issue. So this can be worsening lung issues. This can be ARDS, edema, atelectasis, pneumothorax, air trapping, the autopeep I talked about. So lots of reasons this is an issue with the actual lung parenchyma getting worse. So in our little algorithm of steps, next we're going to try to analyze and fix. So again, a quick chest x-ray. If your patient's x-ray looked great 2 hours ago and now it looks like this, that's ARDS, and they're probably getting worse, and we need to treat that patient accordingly. Using things like your ultrasound to look for edema, to look for pneumonias, pneumothorax, other things that could be going on, and then looking for autopeep as well. So we'll focus on the autopeep. How do we measure autopeep, or how do we get an understanding of if this person is autopeeping on the vent? So how did we measure plateau pressure? Inspiratory hold. How do we measure auto peak? There we go. Excellent. But we can also see it on the vent. So here, this patient is auto peeping. So we have a couple things we'll look at here. First off, our yellow curve up here, our pressure curve. Like I said, there's a gradient here. We expect a gradient if we have PEEP on this machine. So he zeroes down where my arrow is and we go up here. That's our baseline level, our PEEP. So our PEEP on the machine is set at 5, but it's measuring a PEEP of 14. And this just looks like a pretty high PEEP. So that is evidence the patient is likely auto peeping. Also, if we go down to our flow curve here, we have inspiratory flow, that positive deflection. Then we have our expiratory phase. And before the expiration comes back to 0, boom, we have another inspiration. Same thing. Exhaling before it comes back to 0, boom, inhalation. So that tells us that before that patient can fully exhale the breath, the vent is now giving them another breath. And that's going to set someone up for auto peeping. Like I said, if we want to gain a better number on it, we can do our expiratory hold here. And so on this vent here, we can see expiratory hold. And you can see as we do that expiratory hold, that waveform creeps up and starts giving us a baseline run right there. And that's going to be the level of intrinsic PEEP. So on this vent, you can see that PEEP is measuring at 17 and the PEEP on the machine is set to 0. So in this patient, we have a level 17 of intrinsic PEEP, which is a fair amount. So that can change hemodynamics. That can also change the patient's ability to trigger that vent as well. So we want to fix these patients, obviously. So if this is an obstructive pathology, we want to go ahead and treat the patient with more nebs or whatever we're doing. We talked earlier about allowing the patient to fully exhale. And one way we do that on the vent is decreasing their respiratory rate. So you can see on the vent up here, bringing their respiratory rate down to allow for full exhalation. And that's where you start using your waveforms. Start titrating that respiratory rate down and see, does their flow come back to normal? Now, this might be a time we actually need to sedate the patient more because if they're breathing 35 on their own, I can't turn that down on the vent. So I might have to sedate them or even paralyze them to get them to work with the vent better. And also, we consider actually adding PEEP into these patients. Usually around 75 to 80% of your measured PEEP. If you add PEEP to the system with the vent, it's kind of counterintuitive. We'll actually allow airway stenting and allow more exhalation of that air. But again, talk to us, talk to your ICU team, talk to your RTs, get us involved to see how can maybe make this situation a little better. All right, I'm going to wrap up. And lastly, evaluate. Don't just set it, forget it, walk away. Evaluate the patient, look at your monitor, look at the vent, most importantly, look at the patient and take the whole situation in perspective. The takeaways: silence, analyze, fix, evaluate. Don't forget your dopes. It's basic, but it gets you out of a lot of bad situations. Remember resistance versus compliance, and that main answer is going to be in your plateau pressure. Don't be afraid to phone a friend, and then know your vents. I was talking about this back earlier. I had one of the sickest asthmatic patients I've ever had 2 months ago at New Kings at 3 in the morning. And I told the staff, we are not intubating this patient because I cannot remember how to run this vent. This is the vent on the right, and I totally forgot how to run it. So know how to run your vents because it's a scary situation. You suddenly realize, oh shit, I'm not used to this vent. So whenever you end up in a new place, grab the RT, grab someone who knows how to run that vent, say, hey, run me through this real quick. Take out the manual and read the damn thing. Just know how to run it because you are the one that people look to do this stuff. And that is it. Questions? Cool. Dr. Pandey.